Kyunghee Lee walked into the same building, took the elevator one floor higher than usual, and got the same injection from the same doctor she'd been seeing for years. Her bill went from $30 to over $350. The total charge? $13.94 for a steroid shot in her knuckle. Kyunghee is 72. She ran a dry cleaning shop outside Cleveland for 40 years after emigrating from South Korea. Her right hand aches constantly. Once a year, she'd see her rheumatologist, Dr. Elizabeth Roeder, get the injection, hand over her $30 copay, and go home. Late summer 2020, masks on. She drives to the Mentor Health Center in Mentor, Ohio. The office had moved. One floor up. Same building, same paper-covered exam table, same needles, same conversation. Then the bill arrived from University Hospitals. $1,262 of that bill was a single new line item. The category? Operating room services. Kyunghee never saw an operating room. This is the story of how a regulatory loophole quietly turned your neighborhood doctor's office into a hospital. On paper only, and stuck you with the difference. It's called provider-based billing, and it works like this. Medicare set up a system decades ago to help hospitals cover the cost of staying open 24/7. Emergency rooms, trauma bays, uncompensated care. The rule lets hospital-owned facilities split a medical bill into two pieces. One piece pays the doctor, that's the professional fee. The other piece pays the institution, that's the facility fee, for overhead, equipment, the building itself. Now here's the trick. Medicare pays one rate when a service happens in an independent doctor's office. It pays a much higher rate, sometimes double, sometimes triple, when the exact same service happens inside a hospital outpatient department. Same procedure, same room, same hands, different billing zip code. So hospitals figured out the play. Buy the independent practice. Don't move it. Don't change the staff. Just file paperwork with Medicare, reclassifying the office as a hospital outpatient department. The patient sees no difference. The billing sees everything. That's what happened to Kyunghee. A university hospital spokesperson confirmed the maneuver to local press. Between 2019 and 2020, the hospital system moved its infusion clinic from an office-based practice to a hospital-based setting. His exact phrase, "That was a change in definition for billing." A change in definition. That's the entire mechanism. The financial engine has a name, the site of service differential. A standard office checkup at an independent clinic, Medicare pays around $100. Patient copay, about $20. The same checkup inside a hospital outpatient department, $80 to the doctor, plus a $130 facility fee on top. Total, $210. A 110% markup for nothing. For a cardiac echocardiogram, $150 at an independent office. $340 inside a rebranded hospital department, a 126% markup. For Kyunghee's knuckle injection, $30 became over $350. You can probably guess what happened next. Hospitals went on a buying spree. As of January 2026, 82% of practicing physicians in the United States are employed by hospitals, health systems, or corporate entities. In 2019, that number was 62%. Nearly 64% of all physician practices in the country are now owned by hospitals or corporations. Between January 2018 and January 2026, 181,200 independent doctors became hospital employees, each one of them a new revenue source, each one of their offices a candidate for reclassification. Congress saw this coming. In 2015, lawmakers wrote Section 603 into the Bipartisan Budget Act. It told CMS, stop paying hospital rates for off-campus clinics they buy up after this date. Site-neutral pricing. Same service, same price, no matter where you walk through the door. But the hospital lobby got something inserted into the bill, a grandfather clause. Any off-campus department billing Medicare before November 2nd, 2015, exempt forever. When the rule took effect in 2017, more than 98% of existing off-campus hospital facilities were grandfathered in. So hospitals just routed new acquisitions under their existing grandfathered billing codes, or they parked the new clinics inside on-campus medical buildings, which are 100% exempt from the law. The law passed. The behavior didn't change. Ted Doolittle, Connecticut's healthcare advocate, put it bluntly, quote, "They can't just painlessly take that needle out of their arm. They're addicted to it." In 2018, CMS tried again, under the Trump administration. They expanded site-neutral pricing to cover basic clinic visits at all off-campus departments. The American Hospital Association sued. A district judge struck the rule down. The appeals court reversed her in 2020. The fight has not stopped since. Meanwhile, the bills kept arriving. Carrie Green, an Oregon patient, testified before her state legislature about a $92 facility fee she'd been hit with at a rheumatologist's office. Her words, "There's no specialty equipment. Some crinkly paper, gray chairs, a blood pressure cuff machine, and a hand-washing poster on the wall. Why is the charge being levied for that? That's the question. States stopped waiting for Washington. As of September 2025, 20 states have passed laws regulating or restricting hospital facility fees. Colorado banned them for outpatient preventive services as of July 2024. Texas introduced legislation in 2025 forcing hospitals to use location-specific identifiers so insurers can see where care actually happened. Connecticut requires written notice before a facility fee is charged. In November 2025, the Trump administration finalized the 2026 rule cutting Medicare payments for off-campus outpatient drug administration by 60%, aimed squarely at hospitals buying up oncology and rheumatology practices to harvest infusion facility fees. The American Hospital Association has historically sued to block similar Medicare reforms and is expected to push back here too. Here's what's at stake. Blue Cross Blue Shield and the Actuarial Research Corporation crunched the numbers. Full site-neutral reform would save the federal Medicare program $202 billion over 10 years. It would save Medicare beneficiaries $134 billion more on premiums and out-of-pocket costs. Commercial insurance premiums would drop by $107 billion. Total estimated savings across the U.S. healthcare system, $471 billion over a decade. Money that currently flows, quietly, line by line, from patients to hospital systems, in exchange for nothing more than a paperwork reclassification. Kyunghee Lee's family paid the bill, under threat of collections, to protect her credit. She tried to appeal. The bill stood. This is how the system actually works. Not through a single villain, not through fraud, through definitions, through a footnote in a 2015 budget bill, through 1 in 5 American doctors quietly becoming hospital employees over 8 years, through a 1-floor elevator ride in a medical office building in Mentor, Ohio, that cost a 72-year-old retiree over $300 extra for the same shot she'd been getting for years. Same doctor, same needle, same paper-covered table, different